Welcome to Airway Breathing Conversation, a podcast presented by the anesthesiology residents at the University of Saskatchewan, created to provide individuals of all levels of medical knowledge with anesthesiology-related healthcare information. This episode is part of our Abridged Ground Round series, in which highly knowledgeable and sought-after guest speakers present on a multitude of fascinating topics relevant to anesthesia. Join us for Grand Rounds this week, where Doctors Keltie Anderson, Ahmed Cherry, and Henry B., a rheumatologist, orthopedic spine surgeon, and anesthesiologist, respectively, practicing in Saskatoon, discuss their approaches to patients with rheumatoid arthritis in the perioperative period. Now, whether you are an anesthesiologist, resident, medical student, or member of the general public, come listen in as we demystify the incredible specialty that is anesthesiology, one episode at a time.
Hi, everyone. Yeah, I'm Keltie Anderson. I'm one of the rheumatologists in the community. So it's really nice to be talking to everyone this morning. It's a little bit of an ungodly hour for those of us in rheumatology who usually start clinic at 9, but that's okay. So I have a little bit of info to get through today about sort of management of medications in the perioperative period. And I did sort of try to keep this broad. I know the focus is on rheumatoid arthritis, but we do have a few other special patient populations in rheumatology that do get their own kind of mention in the guidelines. So I thought I would just touch on those as well. And I'm going to put my email address in the chat because I will have to dart out early. But if anyone has questions, please feel free to reach out at any point in time. So my objectives today are to discuss the management of DMARDs, biologics, small molecules, and steroids in the perioperative period. And we're really going to focus on the ACR guidelines. We don't have a ton of guidelines in rheumatology, lots of small patient populations, but the ones that we do have in this area are quite robust and get updated regularly. So why do we do surgery in patients with inflammatory arthritis? Well, a lot of it comes down to joint destruction and damage accumulated over time related to the inflammatory disease. So our goals are pain relief, functional impairment, and general improvement in quality of life. We are quite proud of the fact that surgeries are declining over time for rheumatic diseases in our patients. This is an old study now, but there was a retrospective chart review performed from 1980 to 2007 looking at patients with rheumatoid arthritis who underwent surgical procedures. And you can see that those numbers decline steadily. And a lot of that is attributed to tight control of the inflammatory disease. And that leads to changes in the natural history and the progression of joint destruction. But we still have patients who need surgery. So when it comes to deciding on whether a patient is a surgical candidate, there's a lot of weighing of risks that has to go into it. And I know I'm preaching to the choir here. You guys do it all the time. But in my patients, it's really the risk of infection in the post-operative period that we worry about. And we all know that can lead to significant morbidity and mortality. And unfortunately, most of the medications I use impact the immune system in one way or another. And many of them have been shown to increase some infection risks. We balance that with the risk of disease flares that can occur when medications are held. And in some studies, flares are reported in 60% or more of patients around the time of surgery. And that's largely attributed to discontinuing their medications. And in the rheumatology world, we manage flares with steroids, which of course are not ideal as far as infection and healing risk goes as well. So a lot of our patients will have multiple infection risks, and assessing the risk for infection is, of course, complex. There's lots of factors that come into play. Some of them are modifiable. Many of them, of course, are not or not easily modifiable. But anti-rheumatic therapy is something that is easy to stop, and it does sometimes have an impact. So the guidelines are a real focus of the rheumatology community, and they get updated regularly. Some other things, of course, and I won't spend too much time here, but just to note that active inflammatory disease is a risk factor for infection on its own. So if the disease is currently active, or if they've had long-standing disease duration or severe disease, you're already starting with higher risk of infection. And then, of course, steroid use is strongly linked to infection as well. There's a bunch of patient-related factors, which I won't go into. And then, of course, the surgical procedure. So for the most part, I will be talking about higher risk surgical procedures, which we sort of think of as being the joint-related procedures and the intra-abdominal, intrathoracic procedures. For elective surgery, we really prefer that the disease be under good control before the surgery is scheduled. Obviously, everything goes out the window when we're talking about urgent or emergent therapy, and that should be done promptly regardless of what medications the patient is on. So for today, I'm going to be focusing on the 2022 ACR and American Academy of Hip and Knee Surgery guidelines. These guidelines apply specifically to patients undergoing elective total hip or knee arthroplasty, but in the rheumatology world, we extrapolate them to most elective surgeries. The overarching goal is that in order to minimize risk of relapse, we want to interrupt anti-rheumatic treatments as briefly as possible, but also try and be safe. So I am pleased to report that our standard DMARDs, which are most of those oral medications that have been around for the last 20 or 30 or 40 years, are all safe throughout the post-op or perioperative period. So that includes methotrexate, leflunomide, hydroxychloroquine, sulfasalazine, and apremilast, which isn't something you guys have probably seen too much of because we don't have it on the formulary here. The new thing in these guidelines was the addition of leflunomide to the safe list. So we no longer stop this in the perioperative period. We continue it throughout, with the caveat that the level of evidence for all of this is going to be low to moderate. So if you have a patient and you are very concerned about infection risk, it's absolutely appropriate to reach out to the rheumatologist or whoever's prescribing these medications, because conversations with patients about risk and benefit of infection versus stopping drugs is something I do all the time. So I'm always very happy to field those requests and minimize risk as much as possible. Things get a little more complicated when we talk about the biologics. So the current conditional recommendation is to hold it for the short term. So when I started training, we were holding biologics for 5 cycles, which is very difficult for planning. And what we're seeing over time is that the risks are probably not as high as we had thought with the biologics. So that interval has been getting shorter and shorter and shorter. So now we're holding these for 1 dosing interval. Basically, what that means is the patient takes their dose, and then about the time they're due for their next dose, that would be ideally when we would aim for surgery. This would allow surgery to happen when the drug levels in the blood are lowest. But of course, we can make exceptions if the surgery is needed more urgently for symptom management or in patients where things have been difficult to control. So sometimes we go outside of those guidelines. So these are some of the biologics that we have. The number is growing every year, which is very exciting for me, but very confusing for all of my trainees. So there's a whole raft of them, and you can see them there. I'm not going to go through all of them. I do want to draw attention to a few. So the CD20 inhibitor rituximab, that's given every 6 months. So that's really challenging to plan surgery. We're looking 6 months out most of the time for that. And then some of the newer medications like ustekinumab and guselkumab, those intervals are also fairly long. So the more heads up I get as a rheumatologist about surgery timelines, the better the advice I can give to my patients. The JAK inhibitors are sort of lumped in with the biologics, but they're actually small molecules. And they have a nice short half-life. So the conditional recommendation for these guys is to hold them 3 days prior to surgery. Again, you may want to hold them for longer if there's a history of infection risk. Sometimes I'll do a week. And it is important to note that in some studies and in some higher risk patient populations, the JAK inhibitors have been linked to a risk of venous thromboembolism or cardiovascular events. So we may hold them for longer in patients who are felt to be at risk for those events prior to surgery. But the guidelines haven't really addressed that yet. They mostly leave it up to the individual surgeon and rheumatologist and patient to decide. So I did want to touch briefly on lupus because this is sort of a special patient population, and I know it's not rheumatoid arthritis, but it does come up. So the medications we use in lupus are a little bit different than what we use in rheumatoid arthritis. So for non-severe lupus, we would hold mycophenolate, azathioprine, cyclosporin, and tacrolimus 1 week prior to surgery. And belimumab and rituximab we would hold as well. So belimumab is a monthly injection, but rituximab is that every 6-month injection. So we do usually try to hold those around surgery, but it can be challenging. We have some lupus patients who have frequent flares or difficult to control lupus. And in that situation, the decision may be that we continue therapy throughout. And everything goes out the window when we're dealing with severe systemic lupus. So if you have organ or life-threatening manifestations of lupus, the conditional recommendation is to continue all of these medications perioperatively. And this reflects concern about disease flares and the risk of organ damage. Joint disease, generally I can manage, but if we're dealing with CNS lupus and the risk of flare there or lupus nephritis, we usually don't want to run that risk in a patient who has had these issues in the past. If you have severe lupus and they are on rituximab, we do try to aim for surgery in the last month of that 6-month dose, but we would not delay the subsequent dose. And then belimumab, it's advised to continue throughout. And this is felt to be preferable to disrupting therapy. So post-operatively, the conditional recommendation is that patients in whom therapies, we would restart these therapies once wound healing is progressing as expected, the sutures and staples are out, and of course, assuming there's no sign of infection. And so I usually just say 2 weeks after surgery, if everything's going well, we can get back onto the medications. A little word on steroids, because we use these drugs a lot in rheumatology. We always try very hard to get away from them, but there are some patients who require them for disease control. This is a very common medication in rheumatoid arthritis patients. 65% of people with rheumatoid have used them at some point, and in one study, about a third of patients were on therapy at any given time. Obviously, there's a lot of perioperative concerns with steroids, including wound healing and tissue fragility, infection, the risk is dose dependent, hypertension, elevated sugars, and diabetic control. A little word on infection. There was a recent study looking at long-term infection risks in people who have been on steroids at any point in time. And if you have been on steroids for more than a year, you have a permanently elevated infection risk, even if you get off of steroids at one point in time or another. So that brings all of our polymyalgia rheumatica patients and GCA patients into the higher risk fold as well. Our goal with steroids is always to be slow with how we adjust them. So we want to minimize the steroid dose about 2 months before surgery to let everything kind of settle out. There's really no benefit in reducing it in the week or two before surgery. It doesn't improve infection or surgical outcomes, and it can cause disease flares. So we really want to try and keep the doses consistent in the couple weeks preoperatively. As far as stress dosing goes, that has largely been proven to be unnecessary. So all of these patients with inflammatory arthritis, that's rheumatoid, ankylosing spondylitis, psoriatic arthritis, and lupus who are undergoing elective surgery and who are on steroids, to just continue their daily dose. There's really no need to stress dose them on the day of surgery, with the caveat that that doesn't apply to patients who have adrenal or hypothalamic insufficiency. And the rationale for that is because every 10 milligram increase in steroid increases our short-term complication risk by 8.4%. So we really want to try to mitigate as much as possible. But of course, in the post-operative period, if you feel that additional steroids are required, you can administer as needed. So that's the guidelines. Now, of course, guidelines exist in a perfect world. There are always caveats. As I mentioned earlier, if you have a surgery that's urgent or emergent, we don't hold the medication, we don't delay the surgery. You go ahead and you do what you need to do. And interestingly, these guidelines are getting more and more relaxed about how we manage these medications around surgery. I mentioned that those intervals where we hold them have been getting shorter and shorter. There's actually a hospital in Sweden that hasn't stopped any rheumatologic medication since 2009, and their reports are no increased risk of infection. Now, there definitely are some studies that would argue against that. So for now, the guidelines stand. But we know that, as I said at the beginning, if we hold the therapy and patients flare, we need more steroids, and every 10 milligrams increases our risk by 8%. So you get this paradoxical increase in infection risk. So to summarize, steroids are the real enemy here. We've been trying to get people off of them for a very long time. Don't stress dose unless you absolutely need to for other clinical reasons. Elective surgery, don't hold your DMARDs, your biologics. You want to aim for surgery when the next dose is due and then continue to hold the medication for 2 weeks after surgery. For JAK inhibitors, we hold 3 days before and 2 weeks post. And then for severe or life-threatening disease or for urgent or emergent therapy, or surgery rather, we wouldn't hold anything. And when in doubt, please pick up the phone and talk to us. I field these calls all the time. Rheumatologists on call are always also happy to answer these questions. It's usually a pretty easy thing for us to do, and we're happy to provide whatever support you need.
Morning, everyone. So I'm Dr. Cherry, I'm one of the spine staff, and I'll talk a little bit about rheumatoid spine. Thankfully, you don't see this quite often, so there's going to be a lot of extra information here just about essentially the findings of rheumatoid spine and how we actually assess these patients, and then obviously some perioperative work as well. So very briefly, we're obviously just going to have our outline here. We're going to talk about the different types of findings in rheumatoid spine, which are the 3 shown, and then we'll talk about our patient presentation that they mentioned earlier. So when we talk about rheumatoid arthritis in general, this is obviously a chronic autoimmune disease, has extra-articular and intra-articular manifestations. It's a 2-to-1 prevalence between women and men, and occurs more likely between the 4th and 6th decades. In terms of clinical presentation, I won't go through this, but this is essentially the diagnosis required for rheumatoid arthritis, which includes 4 of the 6 findings. And it's usually a slow and insidious onset, but in quite a few individuals, you can actually have rapid onset within weeks or even days. In terms of rheumatoid spine, similar to any other orthopedic manifestations of rheumatoid arthritis, it affects the synovial joints, and this is more prevalent in the cervical spine. It's a significant source of neck pain, and that's what we mostly see these patients for prior to deformity or neurological deficit. And about 50 to 85% of patients who have rheumatoid arthritis will present with cervical spine findings, and usually this is found by flexion extension views of the cervical spine. So perioperative considerations for any orthopedic patients or any surgical patients that do have rheumatoid arthritis, obviously very important to have a good medical history for any of our residents. And then when we look at the other findings such as coronary artery disease, peripheral vascular disease, obviously increase your perioperative complications. Important to note that for any patient undergoing an anesthetic, flexion extension views of the cervical spine are required, whether this patient is getting intubated or not, given the possibility of instability. And this is important for our anesthesia colleagues, particularly when we're having intubation. When we talk about intraoperative neuromonitoring, there's not many talks that actually look into this, and neuromonitoring as a whole has been shown to be mostly not required for any of our surgeries. So when we talk about flexion section views of the cervical spine, this is a very good representation of this. So essentially what we're looking at the anterior arch of the C1 ring and the dens here. So you can see an extension that this, what we call the ADI, the anterior atlanto-dens interval, is quite small, and that increases with flexion. So that is an indication, obviously, of instability, which can be concerning in terms of neurological deficit. I'm not going to go through this too much, but obviously the cervical spine anatomy is important for this. And what's actually more important to this slide right here. So particularly for a lot of these patients, the post-operative or the operative procedures require either a C1, C2 fusion or an occiput to subaxial fusion. And you can see, particularly if you talk about an occiput to C1 fusion, you're losing a significant amount of range of motion for the cervical spine. So the C1 section, the occiput to C1 range of motion provides about 50% of our flexion flexion extension. And then our C1, C2 gives us about 50% of our rotatory movement. So fusion of these joints causes a significant decrease in range of motion and subsequently has effects on the patient's clinical outcome postoperatively. Again, when we talk about clinical presentation of all comers in terms of rheumatoid spine, about 40 to 88% present with headaches or occipital neuralgia due to irritation of the C1 and C2 nerve roots. Neurological deficit occurs in about a third of patients. Premature death can also occur due to basilar invagination and respiratory compromise. And obviously our physical examination, primarily we're looking for upper motor neuron signs such as myelopathy, hyperreflexia, and ataxia. So when we talk about cervical spine involvement, there's three main things we look at. In the upper C spine, which is the C1, C2, and the occiput, you can have AA subluxation or atlantoaxial instability, which is the most common presentation up to a quarter of patients. Basilar invagination, which essentially means the dens or the C2 goes through the foramen magnum, occurs in about 8% of patients, and this is very important to catch, particularly because the risk of death is quite significant. And then we talk about subaxial involvement. There are some less common presentations which can occur as well. So when we talk about atlantoaxial instability, once again, rheumatoid arthritis affects the synovial joints, which results in loosening of the transverse ligament around the atlas. That causes instability of C1 on C2. And this occurs up to, like I said, 25% on average, but some papers even mention up to 50% of patients essentially present with this. There's less common presentations as well. Essentially, any range of direction you can have instability depending on what gets compromised. So if you affect the transverse ligament, which stops the C1 from moving forward, you have disruption there. If you have disruption of the dens, you can have posterior subluxation, and then lateral based on destruction of the lateral masses. Again, these patients present with neck pain, neuralgia due to irritation of the nerve roots, and our upper motor neuron signs. And what's interesting is patients can develop vertebrobasilar insufficiency, which essentially means that the vertebral arteries become compressed, and these patients can present findings with this. Won't go through these classifications, but obviously it's been studied historically quite significantly. And these are really our main imaging that we do find, at least screening these patients. So again, we look at our atlantodental interval, which is the ADI, which is this anterior area right here. And you can see that this is increased within anything above about 9 millimeters indication for surgery. We can look at the posterior dens interval, which essentially gives us an idea of how much cord compression there is as well. And anything less than 14 is a concern for neurological deficit. And some studies have shown that less than 13 millimeters may be predictive of neurological recovery. You can get further imaging, such as odontoid views, to see if there's translation of the C1 and C2. But really, all these patients should get advanced imaging. So a CT scan will give us any osteology concerns, so they can have erosive bones, they can have, such as this patient, significant bone density loss, which obviously is problematic when we talk about fixation for these patients who already have a very high risk of non-union. You can also obtain CTAs, which will look at your vertebral artery anatomy, which again is for concern intraoperatively. The mainstay for these patients, however, are MRIs. So this is a patient who you can see has instability, so they have anterior subluxation of C1 on C2. This patient does not have a pannus, but what often these patients can present as well as a posterior pannus behind the ring of C1, which also contributes to compression. In terms of our natural history, these patients often progress with a very small percentage stabilizing spontaneously. This again results with neurological deficits and the requirement for surgical manifestation. Our surgical indications are pretty simple. Persistent intractable pain due to deformity or instability, neurological deficits, and impending neurological deficits. So this is where the flexion extension views are quite important. So if you have an asymptomatic patient who presents with either an increase in his ADI or a PADI, they would be somebody who'd highly recommend surgery due to the possibility of instability and significant spinal cord injury. The goals of surgery, quite simple. You want to relieve their pain, you want to maintain the alignment or improve their alignment of their spine, and then decompress if there's any neurological compromise. These patients have an increased risk of progression of disease, and if this untreated actually leads to worsening symptoms such as basilar invagination, which we'll talk about shortly. Very briefly, we'll go over the different types of fixation. I'm not going to go into too much management for this, but essentially, for these patients, you want to stabilize the C1 on C2. So there's different types of constructs we use. The most common one that I have been involved in is this top, which is the Gohl-Harms technique, which essentially is a screw and rod technique. The Magrill technique, which shows better fusion rates, is a little bit more demanding technically. But as you can see here, there's significant concerns with what the anatomy finds, right? So you're working right above the C1 and C2, where you have the vertebral arteries, which traverse about 1.5 centimeters off the midline. So risk of vertebral artery injury is not insignificant. You also have the C2 nerve root, which travels right below here, which can cause nerve irritation. And historically, surgeons used to take down the nerve root, which we no longer, most surgeons don't do due to irritation and postoperative pain. And finally, surgery in this in itself, there is a very big plexus of veins here that you can have significant blood loss intraoperatively. Historically, we used to use wiring techniques, but there's obviously complications that can occur with that as well. When we talk about overall morbidity and postoperative care, mortality for these patients historically is between 5 and 15%. Non-fusion rates up to 50%, so obviously this is quite problematic. Infection rates up to 25%, and these patients used to and most often still require postoperative bracing. And as I indicated, there's significant range of motion limitations postoperatively, even for a C1, C2 fusion. So this is that transarticular technique that I mentioned with what we call a sublaminar wiring. In terms of these three techniques, so for dorsal wiring, they had a significant high non-union rate. The posterior arch is essentially used to hold us in situ, used to fracture, and you can also have dural or spinal cord injury when we're passing our wires. With the transarticular screw, there's still, even with navigation, up to 15% of malposition. And when we think about it, if you malposition more medially, you hit the spinal cord, you malposition laterally, you hit the vertebral artery. Those are both bad days for anybody. And vertebral artery injuries are still up to 4%. When we talk about C1-2 fixation, again, malpositioning, which you can injure the vertebral artery or the neural compound, you have up to 4% injury or malpositioning in the atlas, which is the C1, and 7% on C2. There has been some case studies talking about rod migration. So essentially the rods start invaginating into the base of the skull, which can obviously cause complications and vertebral artery injury. So we talk about basilar invagination, which is the most concerning finding of these patients. So what you can have is essentially erosive changes of C1, which results with the dens translating into the base of the skull. This can occur up to a third of patients with rheumatoid arthritis, but usually patients with significantly advanced disease. Once again, they can have a pannus, which is a soft tissue formation, which adds to their compressive symptoms. The risk factors for these are patients who have a longer duration of disease, more likely to be male with a positive rheumatoid fracture, prolonged steroid use, which results in the worsening of the erosion of the C1 ring, and increased inflammatory markers. Again, clinical presentation for all these patients are quite similar. However, for basilar invagination, what the issue will be is that if you have vertebrobasilar insufficiency or the compression of the vertebral arteries, you can have other findings. Similarly, if there is significant translation and impingements along the base of the medulla or the cerebellum, you have these other findings of brainstem compression, which can result in sudden death. Here's a perfect example of a patient here who has a basovascular invagination, and you can see significant compression would be causing here along the spinal cord and the base of the skull. We won't go through all of these different radiographic findings, but these are important for the residents or our colleagues to look into, essentially, which are indications of basilar invagination. So everybody essentially has their own criteria that they can follow, but these are all looking at to essentially the positioning of C2 on the C1 ring or at the base of the skull. Again, the most important finding or what's investigation for these patients are MRIs. So you can see here the cervical medullary angle, which is usually greater than 135, can be significantly compressed with these patients. You can imagine they can have quite severe findings neurologically. Again, CTA and CT scans are important for bony anatomy. Surgical indications are similar for the other patients. Any neurological deficits, intractable pain, and obviously any compression of the base of the skull. So in terms of management options, these patients are obviously at higher risk of mortality without surgery, given their compromise and their possibility of respiratory decline. Cervical traction can be trialed in these patients. Essentially, you want to try to disimpact the C2 ring from the base of the skull. Otherwise, we have to do quite complex surgery, which I'll show you an image of shortly. These are for the reducible cases. For irreducible cases, you essentially have to do an autointectomy. I've been involved with one of these. I hope to never have to be again. But essentially, this can be either transorally or transnasally, where they go through the front of the soft palate and essentially resect the odontoid if the patient is unable to have a reduction of the dents over the occiput. These patients have significant complications postoperatively. If they have the transoral, these patients have to have feeding tubes after surgery. Dysphagia and dysphonia postoperatively are quite common. Obviously, risk of infection is quite high. These are a little bit less if you do a transnasal resection, but you have to have a very skilled ENT surgeon to do this, given that this has to be done endoscopically. Again, in terms of surgical morbidity and postoperative care, these patients have a high risk of infection, up to 25%. Head malpositioning is an important thing for these patients, is particularly if you're going to fuse from the occiput to the subaxial spine. You can imagine you losing at least 50% of your flexion extension, at least 50% of your rotation. So these patients can have postoperative dysphagia and unfortunately can have aspiration and aspiration pneumonia due to this. And finally, with any of our surgeries, there's high risk of malpositioning with screws, which can result in things such as cerebellar bleeds and the need for craniotomies, which have been shown in case reports, venous plexus injury, or CSF leaks. The last of the three is subaxial subluxation. So essentially, this is any subluxation or changes in the cervical spine below the C2 level. This occurs in, again, up to a third of rheumatoid patients. You have a stepladder type appearance, which I'll show. And again, you have the cord compromise from the same findings as our previous patients. And this can be accelerated by previous fusions. So we try to limit the range of motion, to keep the range of motion by doing a C1-2 fusion, but unfortunately, these patients usually progress quite quickly in the subaxial spine. Again, this occurs usually at C2-3 and C3-4, and this, is more likely an anterior subluxation. And you'll see here that a quarter of patients who underwent atlantoaxial arthrodesis significantly degeneration within 8 years. So this is your typical MRI of these patients. You'll find that they have significant subluxation. They can have a hyperlordotic or a change in their alignment, disc space narrow and erosive changes, which you can see here, and obviously the facet joint changes. Our surgical indications are similar to our other findings: any progressive deformity, any intractable pain, as well as neurological deficit. And again, the treatment goals are once again very similar. We're looking at pain relief. You decompress where there is areas of spinal cord compression, and you want to stabilize and realign the spine. An important note for any of these patients is often when we stabilize their cervical spine, the pannus formation or the increase in synovium often resolves on its own. So if there's an anterior pannus, we often don't have to go after it. Overall, kind of summarize things before we close off. So for rheumatoid spine overall considerations, you obviously want to optimize these patients if you can preoperatively, and these are combined assessments with our colleagues with GIM and anesthesia. Again, neuromonitoring has not been shown to be significantly required for these patients, but is always important to have if possible. If you can and if you have the time to, preoperative reduction is important, but there is note that regardless of what we do, there is significant risk of infection. So once again, these patients, about half do not fuse, about a quarter become infected, which is obviously significant for them. There only has been a few meta-analyses looking into it, given that we don't see this quite often anymore. There's no real change in the surgical time between rheumatoid and non-rheumatoid patients. They often have prolonged hospital stay, and they have at least a 2-time increased relative risk in complication and hardware failure compared to their non-rheumatoid colleagues. Just to show a perfect example, this is actually the patient presentation that we mentioned before. You can see here, this is an MRI obtained in September of 2020, which showed a somewhat stepwise deformity, obviously with some mild cord compression. This was treated without surgery. And you can see within 1 year, he had multiple levels of compression, multiple stepwise deformity. And this is a patient who was on anti-rheumatic drugs. This is the index surgery which was performed. I apologize, I wasn't able to get rid of these markers, but you can see that his stepwise deformity was reduced quite nicely. Unfortunately, I can't see the bottom of the screen here, but you can see that there was some improvement, and he actually did quite well after his first surgery. However, you can see quickly here, again, 2021 was his index surgery. This is 2 years later, and again, he is on biologics. You can see that he had erosive changes, and they call this a fracture. This is likely an erosive change of the of C2 of the dens there, resulting in this compression posteriorly and anteriorly. He had a pannus here, again, and significant compression both at the proximal and distal end of his fusion construct, which unfortunately we see in these patients. This is the right there. And this is essentially what he got when I was done with him. So basically he obtained an occiput to T3 fusion. This allowed me to decompress the C1 ring, to reposition his odontoid, as well to bypass his previous fracture and the erosive change at T2. Unfortunately, this patient kind of fell into the same context of all these patients with rheumatoid arthritis. He did develop a postoperative infection and unfortunately did pass away about a month after surgery.
Okay, everybody. I don't have that many slides, so we're going to just power through this and then we can do Q&A. I'm sure lots of people have good questions for all of our speakers today. So just a warm welcome to everybody from all the departments, it's great to see everybody here today at our combined rounds. So in the interest of time, there's lots of things we can talk about in terms of anesthesia considerations for RA. So I'm just going to focus on airway today. I think you can almost do a separate talk entirely on the pulmonary system, the pulmonary hypertension, restrictive lung disease, ventilation strategies, and cardiac stuff, like arrhythmias and things, but that'll just be way too long. So we'll just do airway today. And just a very quick dumbed down version of what Ahmed was teaching us, because this is me. This is like me digging deep into the Netter's Atlas from when we went through medical school here. So for the atlantoaxial subluxation, of course, that's probably what we worry about the most, right? From an anesthesia perspective, when we manage the airways in these kind of patients. If just a quick refresher using like a simple diagram like this, that joint is formed by the dens process of the axis, as well as the anterior arch process of the atlas. And the dens, also known as odontoid, it's basically supported and held by that ligament. So when you have in this disease process attenuation of that ligament and erosion of the dens or the odontoid process, that's what leads to eventually atlantoaxial instability and spinal cord compression, which usually happens in where you see that red arrow there. So, and as Ahmed alluded to, there's multiple classifications. This is a Fielding classification. We'll look at type 1, 2, 3, and 4. Which increases in severity, going from anywhere from just simple unilateral anterior subluxation to eventually bilateral. And then incidence, if you look at literature, it's all over the place. But I really have to remind people that incidence does not equal severity. So I'm not saying every single time you see a patient with rheumatoid arthritis, you should be sending them from PAC clinic to MRI and out of fear. I would approach this very much like you would with any other cardiac issue. If you look at mild mitral regurgitation, I think there was like a 1990 study that looked at like hundreds of volunteers, healthy volunteers between the age of like 18 and 80 years old. And they found that like 48% of people had mild mitral regurg, So just because you have mild mitral regurg is not going to change at all what your anesthetic management is, right? So I think you have to correlate a lot of things with symptoms and clinical suspicion, good discussion with spine surgeon as well as your rheumatologist and all that, and not just think that just because they have that higher incidence that it correlates with higher severity. So like Ahmed had said, MRI is a much, much better tool than just doing a spine radiograph. But even then, that often correlates quite weakly with clinical symptoms, and you have different stages of what could happen. But very rarely, I would say, you see them in the late stages where they have that instability coming through PAC clinic. Usually, if you do, like they're either, most of the time, I would say, if I see a patient with RA coming for an unrelated spine surgery, like let's say coming for a gallbladder or something like that, they're asymptomatic from a C-spine perspective, right? So, and then looking at this article that came out in 2023, they found that the actual incidence of like severe atlantoaxial subluxation in 700 patients with RA was only about 2.1%. And as Ahmed had alluded to, the risk factors that they had identified were male, having a long disease duration, ACPA antibody positive, extraarticular manifestations. So then they did something else really cool. They took 30 asymptomatic patients who had all 4 of these risk factors. And then they did further in-depth imaging, and they found that subclinical atlantoaxial subluxation happened in about 50% of those patients who were asymptomatic but had all these disease processes. But once again, like I said, these were subclinical. And then I won't go into depth of this. Ahmed had done a wonderful job kind of talking about both. These are all less frequently occurring forms of rheumatoid cervical spondylitis, but usually the A instability is what we worry about the most, and those are the ones that you quote often on our Royal College exams. So, but if you want to really impress your examiner, you can drop these two, and they'll probably have no idea what you're talking about, and you'll probably pass your exam. And then the other airway things that from an anesthesia side, they'll often want you to say on the exam, and you'll often see in textbooks, would be TMJ disorders. That's pretty self-explanatory, just a very limited mouth opening. And you can imagine if you combine that in somebody with already present atlantoaxial subluxation, it would be pretty much a nightmare airway. And then you can also have cricoid arthritis, which once again is not to do with the muscle, it's to do with the cricoid joint, which is formed by the base of the arytenoid as well as the top of the cricoid cartilage. And so just a quick reminder, like this, the reason this joint is really, really important is because, and you see these symptoms I had listed up there, such as shortness of breath. Hoarseness is probably the most common symptom presentation. About 35% of people with cricoid arthritis will have this. The reason you get this is because that the cartilage is a very shallow ball socket joint, and rotation and movement of this joint is what allows your vocal cords to abduct and adduct, causing phonation and as well as breathing. So that's why when you have issues with this, so a classic, I wish I had included a picture of this, my apologies, but on direct laryngoscopy, what you would see is obviously not your vocal cords being edematous, but it's just anterior to your vocal cords. You would see quite a bit of swelling. And like I had said, bilateral is very, very rare. And unilateral is way more common. So you would often see quite a bit of swelling and like a mass-like edematous structure just anterior to your vocal cords. And, something to be concerned about is, when you have prolonged prone surgery, you already can expect a little bit of airway edema. And then if they have pre-existing cricoid arthritis, I think you'd for sure have to do like those negative pressure cuff leaks and all that stuff before you can safely extubate. So this is probably the more relevant part of the talk, which we're just kind of talking about different adjuncts of airway management. And for those of you who don't get excited about this, and this is probably a good time to look at TikTok or check the stocks, which are probably not doing great. So this is like a really good article that I have found, which kind of did a really good comprehensive review of like all the evidence that literature that come out. Surprisingly, a lot of the really good stuff have come out in recent years. Like if you go back in even the early 2000s, like there haven't been that many really good studies. So this first study, it came out in 2020. They looked at about 20 different patients who are in C-spine collars, comparing the CMAC D-blade with direct laryngoscopy, and they've unsurprisingly found, using just lateral fluoroscopy radiographs, they found that the CMAC produced less cervical movement at the C0, C1 level, and then C1, 2, and C2, 5 movements were about the same, which is a little bit surprising. And then in a similar year, they did another study looking at using cadavers, which they had surgically created C-spine instability, and then they compared like a regular MAC blade. And for those of you who don't know what these jargon means, so the regular MAC blade is like that big metal shovel thing we use. And then the glide scope is like the one with the little fancy cameras. And the CMAC is the one that is, it looks like a regular MAC blade, but it's hooked up to a video screen. Okay. McGrath is very similar. They're just different brands, but essentially it comes down to think about it as like the traditional intubation versus having a video in front of us. And so in this model, the MAC blade was the worst. So that's just doing direct laryngoscopy in terms of displacement. So, but if you compared all the other video laryngoscopy techniques, they caused basically similar displacement. And then in 2018, they had looked at a cadaveric model as well, which in this time, instead of just using simple lateral fluoroscopy, they actually looked at changes in the dural sac width using myelography during intubation. And they found, and they also created a atlantoaxial dislocation surgically in these cadaveric models. And they found that comparing once again, the traditional MAC blade versus video laryngoscopy, direct laryngoscopy resulted in medial reduction in dural sac width of about 1.6 millimeters compared to video laryngoscopy about 0.9 millimeters, which is like, that's a significant difference, but these studies don't really correlate with actual symptoms. So that kind of leads us to looking at the next step up, which is then comparing video laryngoscopy to awake fiber optic intubation. Classically, when you hear about awake, unstable C-spine, the classic exam answer is usually you try to do it awake fiber optic. There's been 2 studies that have kind of compared them, higher quality studies. So 2020, they did an RCT comparing awake fiber optic, which we topicalize the airway and intubate them with a very soft, flexible fiber optic scope with the endotracheal tube attached to it. And you compare that to doing an awake, basically glide scope, okay? And people who have known C-spine instability. And there was greater change in the lateral angulation at C1-2 with video laryngoscope, which is not surprising at all. But more importantly, at C3, the movement was the same. A similar year study, they looked at a randomized crossover trial comparing, now instead of the previous study, they looked at awake, this one they looked at asleep, but essentially the same. And they found that flexible bronchoscope caused a smaller reduction in movement at those 2 important levels. So once again, like the other studies, which they compared direct to video, none of these studies really correlate with actual symptoms or any intraoperative nerve monitoring. So that brings us to probably I think this is the last study I have, which is, I think this is a really cool study. I didn't even know this one existed before, but they looked at 40 patients with actual traumatic, unstable C-spine fractures in a C-spine collar, and they did do sensory evoked potentials at 4 different points. So they did a baseline, face mask ventilation, intubation, and surgical positioning. And they compared doing an asleep fiber optic versus an asleep video laryngoscope. And before I get into the results, Ahmed had alluded to this, but putting patients in sniffing position is probably not a super great idea. It puts a lot of hyperextension issues on that joint, which may also already be unstable. Sniffing, both putting a patient with a chin tilt as well as a jaw thrust. I actually, don't quote me on this, but I think one study that I read preparing for this said jaw thrust is actually worse than chin tilt, just in terms of pressure on the C-spine. But so what they found was quite interesting. So they found that during intubation, there was only significant SSEP change in one patient. And then during face mask ventilation, there was also just 1 patient who had change. The vast majority of sensory evoked potential changes happened during surgical positioning. So when we were trying to be as delicate as possible and the whole team, sometimes there's like 6 of us trying to turn the patient and without moving the neck too much at all. And anybody who's ever been in the OR doing that knows it's extremely challenging, despite our best efforts, to not move the neck a little bit at least. But what's reassuring, I guess, is just from this small limited study that no patients with significant SSEB changes during this process presented with a worsening of their neurological status at discharge. So it's not a super strong correlation. I don't even know if that was even strong enough to power that with just 40 patients, but it's somewhat reassuring to know that a transient change like that doesn't result in globally worse, likely not, compared to significant, I'd imagine, fluctuations intraoperatively or looking at those amplitudes and things then. And I would probably view this in similar regards to that brief hypotension we sometimes get right after induction. There's been lots of studies to show that that very early on brief hypotensive episode right after induction that's usually iatrogenically induced has 0 correlation with 30, 60, 90-day mortality and morbidity. So, and one of the limitations of the study is obviously they didn't do any monitoring of cortical spinal activity, which The reason for that is they probably had the patients paralyzed for the intubation, and they just wanted the medication to wear off before they started doing the other stuff. So that's probably why they didn't include that.
You've been listening to Airway Breathing Conversation, a podcast hosted and presented by the anesthesiology residents at the University of Saskatchewan. Please note that while this podcast is run by healthcare professionals, it is intended for educational and entertainment purposes only. We are very thankful to our guests for taking the time to share their wisdom with us this episode, and a very special thanks to you, our listeners, for tuning in. Don't forget to follow us and our associated USask Anesthesia accounts on social media. You can find all our social media links on our Linktree page at linktr.ee/abc_podcast. You can also find the department's social media links on their Linktree page at linktr.ee/usask_anesthesia. We'll see you next episode, but until then, stay calm, take a breath, and always remember your ABCs.